that's where we have to remember the variety of patients in the same way we remember the variety of humans. And when it comes to anti-seizure drugs, no single drug is going to work for the same seizure for every different person. You can have two different people with the same seizure type, and one drug might not work for them. It might work better for person A, but not person B.
So moving on to neuroanatomy, and I've got my notes here. Let's talk about the reticular activating system, which is an absolute, I mean, when I was listening to your lecture, I could tell these are one of the things, these are the things that really get you going. Like the intricacies of this stuff. And it's a super fascinating system. So can you paint a picture for us what the reticular activating system is? And if there's a specific part of the brain where it's actually located, neuroanatomically speaking, that's a word.
We'll make it a word.
Neuroanatomically?
Yeah, it's a word now.
Oh man, we did it.
All right.
But yeah, what's the RAS, as you say?
The reticular activating system is located in the core of the brainstem, going from the midbrain all the way down to the medulla, and is made up of several different groups of nuclei. That's to say it on neuroanatomy terms. Yeah. For the uninitiated, we have bundles of brain cells that group up together and they work together, kind of like microchips. And the reticular activating system is a network of these brain cells throughout the brain stem. And they're right in the center, in the core of it. And one of the major jobs that they have is to produce some of the most important neurotransmitters that we have, such as serotonin and noradrenaline, just like norepinephrine. And then there's a bunch of other neurotransmitters being produced there. The reticular activating system is also involved in consciousness and arousal. So when we are aroused, meaning our attention is drawn to stimuli, or when we wake up or when we fall asleep, the reticular activating system is performing different functions to make all that stuff happen.
When I listened to one of your lectures, you had said that there was a oscillating neuronal firing. Can you kind of explain that? Explain how that frequency of the oscillating firing, how it might fit into the EEG.
Yeah, absolutely. So, disclaimer, I am simplifying because it's a really complicated thing, and it's hard to really get it across without simplifying. But in simple terms, we have a lot of really complicated networks in the brain that drive some of our central rhythms, such as our posterior dominant rhythm, which is the alpha and the occipital lobe. So directly, there's cycles between, or circuits between, the thalamus and the occipital lobe that helps drive the alpha rhythm, the posterior alpha. But at the core, to use that word here, we have the reticular activating system, which again helps control whether someone is awake or asleep. And it's not so much an on-off switch. You turn this RAS on and they're awake, and you turn off and they're asleep. There's several different ones. One turns on to make them go to sleep, and one turns on to make them wake up. So while we are awake, the reticular activating system itself oscillates at a frequency somewhere around the range of 8 to 13 hertz, which may sound familiar to you as the posterior dominant rhythm, is the alpha range. So while we're awake, it's firing 8 to 13 hertz, and it has these diffuse connections throughout our whole entire brain. With the image of the RAS that we have the arrows that are pointing out to all different parts of the cortex, and that's the axons from the RAS just spreading around the whole brain, dropping neurotransmitters all around and having these diffuse connections. So when we're awake and we're looking around and we're looking at each other like we are right now, our occipital lobe is active and it's firing at whatever frequencies the neurons are firing at, and usually more in like beta range and stuff like that, because they're busy, they're active, right? And so if we had an EEG hooked up to us, we would see very low amplitude, attenuation. We say attenuation because we're comparing to the posterior dominant rhythm, but we see faster, lower amplitude activities. Then when we close our eyes, then our occipital lobe, it goes idle. It's like putting your car in neutral for those that know how to drive a manual. So you're putting your car in neutral here. You're putting your brain in neutral. and it doesn't turn off. Your occipital lobe visual cortex doesn't turn off when you close your eyes. It just goes idle. And so the rhythm of idleness is alpha. We also see that in the sensory motor cortex. When our patients become physically relaxed and idle, we see mu rhythm.
Yeah.
Right? So with the occipital lobe, our patients close their eyes. All the busyness of those occipital cortical neurons starts to go idle, and they're driven by the reticular activating system, directly by their connections with the thalamus, but at the root by the reticular activating system.
And that's fascinating to me, because when I first understood alpha or or PDR, I know those aren't interchangeable. But when I first understood alpha in general as the PDR, post-dominant rhythm, it was just, it's so beautiful. And, you know, I think people who know how to read an EEG, people listening to us talk, when we say, golly, that's a beautiful seizure, or that's a beautiful PDR, or that's a beautiful sleep architecture. I think people who don't read EEGs or aren't educated in EEGs are like, what are you talking about?
Yeah.
So I love what you just described, because it is exactly what I fell in love with when I first started reading EEGs. I didn't know it was the RAS that was, you know, contributing to it.
Me neither.
But I just knew it was just, that's what happens when you close your eyes. Yeah. Fascinated by it. And I also think it's funny that, you know, you hear all the time, you know, I want to stop work. I want to go to the beach and I want to turn my brain off. What they're really saying is, right, is I want to put my brain into idle mode.
Right.
Because is your brain ever turned off?
It's never off.
Right.
Our whole entire brain, always active at all times.
And it's whenever you're asleep too. I think it's funny that that's another thing, a common misconception is that people think that their brain just turns off. And it's the most wild looking EEG whenever you're in deep sleep or the beginnings of stage 1, stage 2, all these different patterns that pop up. And it's just fascinating to me. And yeah, I had that kind of thought before I got into EEG, before I started really learning what EEG patterns were. And the more and more I got that, and I'm curious if you're the same, but like the first time I understood a K complex and how to elicit a K complex, like with some sound, and then you saw it on the EEG, that's what hooked me. And I think a lot of people, they're curious of why we're so passionate about it. It's times like that whenever we see a K complex and we remember that first feeling of, I can read this now.
Yeah. Yeah. And I think one thing that is common among almost everybody, if not everybody that I know in this field that does EEGs or any part of neurodiagnostics, is we have this thirst for knowledge. We are eternal learners. And I know that can be said for most of humanity, but we are really, truly passionate about learning new things. And it can be anyone from someone who is in school, just graduated, or has been in the field for 10 or 30 years.
Yeah.
And so when we see these things and they bring us back to the time when we learned, when we originally learned about it.
Yeah.
And those aha moments.
Yeah.
Those aha moments where we finally understand, okay, so antero-posterior gradient, or that's the posterior dominant rhythm. Yeah. That's what background means. Something so innocuous is that.
Yeah.
And those aha moments are really some of the most defining moments of our careers, I think.
100%. And it's so niche what we do. And it's so helpful for so many people. And there's, even neurologists, I think a lot of, I see techs who can read an EEG 10 times better than a neurologist can. Yeah. I mean, it really is it's almost an artistic skill that we have. Yeah. And then, and I think that channels the right side of our brain to where we're like, hey, this is an art. This is like really cool. Yeah. And then you can dive as far down deep as you want. You know, you can really get into the nuances of an EEG because it's fascinating because you've heard this cliche within our industry is you get 10 different neurologists or 3 different neurologists to look at an EEG, you're going to get 3 different answers.
Right.
Because it's a skill, it's an art, and it's not subjective to the point where an EEG is not useful, but there's so many factors that go along with it.
Right.
That you can come up with your own theory of what's going on through however much you've looked into it, whether, they have a family history of seizures or the medications that they have. And man, it's really cool that we're in this industry.
Yeah.
But
it's like learning a new language.
it really is. Yeah. It really is. It's like reading. It's like, I don't know if you remember, but I remember being in high school and we had typing class. And I loved typing class because it was a new way of communicating. It was something that I was understanding that I didn't really set out to understand. Mm-hmm. But I took this class and just figuring it out really just sparked an interest. And I can kind of compare that to when I first started. Oh, that's alpha rhythm. Okay, now I know one pattern that I can distinguish on an EEG. What's the next pattern I could do? Really cool.
See it.
Absolutely. So speaking of frequencies, is there a relationship between the alpha rhythm, the beta rhythm, or is it just random frequencies happening at different intervals?
Well, I think the best answer for that would probably be yes, except for when it's not. Mm-hmm. Which is a common answer I give for anything EEG related.
Yes and no.
Yeah. So when it comes to drugs, absolutely yes. In general, there's different generators for whether we're talking about alpha, theta, beta. So there's different generators for our slower and for our faster frequencies when it comes to physiology of it. But related to the topic at hand of medications, absolutely. So when it comes to alpha and beta, like I was referring to with the reticular activating system driving alpha, and how we start to see more beta and faster frequencies when parts of our cortex are not idle. There's that concept there is synchrony. It's our cortex being synchronized with the reticular activating system. And of course, all the other components in between that make it all work. So when we take medication, especially central nervous system depressants, and a lot of these drugs are CNS depressants, what's going to happen is it's going to start to suppress or maybe drive activity in the reticular activating system. And so when we suppress that activity, or when we change it, we cause desynchronization between the RAS and the cortical areas, right? And so with that desynchronization, what that looks like on the EEG is you start to see an increase in faster activities, usually things in the upper beta bands. So you might see more beta activity around 20 to 30 hertz, not so much in the lower beta. And where we see that tends to be in the frontal lobe. Mm-hmm. So on the EEG, we see what we call frontal beta or beta buzz, where you'll see that little spindly or higher amplitude beta coming up in the FPs, EFs, and at the same time, you may also start to see a loss of the posterior dominant rhythm or alpha frequencies if the dose is high enough. So especially when it's enough of a dose to maybe start seeing some visual changes in the person, like maybe they're a little more tired, they're lethargic maybe because the drug is making them sleepy. So we'll start to see an increase in beta frequencies. And as the dose increases or as the effects increase, then we're going to start to see a loss of alpha frequencies or decrease of the alpha frequencies. And that is the basic relationship we tend to see with our on the EEG with these frequencies. It can continue down a whole scale where we start to see even more beta and a loss of even more alpha and even more beta, and then start seeing slower frequencies like theta and possibly even delta. And if we continue this desynchronization and go even further, we can start to see even burst suppression periods where we're just seeing bursts of activity, then mostly suppression, and continuing to increase the amount of the drug there will increase the suppression periods. eventually to the point where we have an isoelectric EEG.
Wow.
Now, depending on the drug, you will have different doses that will cause that. For our benzodiazepines, our barbiturates, the things that we will see more often, it's very unlikely we're going to see anything that drastic, that significant, because it's going to take much higher levels of that drug than what are typically prescribed. So even at overdose levels, where we can see acute intoxication, we don't necessarily tend to see burst suppression from barbiturate. We'll tend to see abnormal activity.
Right.
We can see things like a beta coma or spindle coma, where a patient is unresponsive because of the CNS depression, and we're seeing a lot of beta, but we're not seeing any other activity, no posterior dominant rhythm or anything. But even then, we don't tend to see burst suppression at those high doses.
Wow, I did not know that.
Yeah.
I would have assumed that at any level high enough that you would get that burst suppression pattern, but you're saying that's not the case.
It depends on how much of the drug is being given.
Yeah.
So on the flip side of that example, something like propofol.
Mm-hmm.
Propofol, we can start to see burst suppression at some smaller, more moderate doses. I've seen patients who are on infusions of propofol that are at 50, 60 micrograms per kilogram per minute. Not to get too dosey with it all, but that's a smaller dose, and I've seen them in burst suppression. But I've also seen some patients that are at 75 to 100 and aren't quite yet in burst suppression. But that's a drug that is known to cause burst suppression. Whereas barbiturates, benzodiazepines, they're not really known for it, but they can potentially cause it if you give enough to the patient where the brain is being shut down in such a way.
Interesting. And I'm gonna ask a silly question, but that's my job to ask you silly questions. So when a drug gets into the burst suppression, when it's the absolute goal to put them in like a medical burst suppression, medical coma, is that considered, going back to the therapeutic index, is that considered in the toxic levels? Because whenever I think of the bar, the threshold going past toxic, I think it's all bad. But when you're thinking about going into burst suppression, is that technically going into the toxic levels of that therapeutic index?
I think it would depend on the drug that you're using and the purpose of that drug.
Right.
If benzodiazepine is being given with the purpose of treating anxiety, because they're anxiolytics, that's the primary reason for those drugs to be prescribed. The other reasons, a ton of other reasons, but if it's being prescribed for anxiety, for insomnia, or even just to stop an acute seizure in progress, then burst suppression is not what we're expecting to see.
Right.
And it's not what you would see with those typical doses.
Right.
So in that case, with a drug like a benzodiazepine, it would likely be way over that minimum toxic concentration.
Okay.
Whereas a drug like propofol, which is made to induce anesthesia. So it's made to induce unconsciousness and amnesia, and it puts people out.
Yeah.
They still might not be in burst suppression when anesthesia has been accomplished. But it is also possible to for some patients to reach burst suppression when they are in that therapeutic range.
Wow. Yeah, I did not know that. I've heard through studies that anytime a drug affects the central nervous system, CNS for us who talk about it all the time, we don't want to continually say central nervous system, it likely affects the EEG, right? So if a particular drug affects the CNS, it likely will affect the EEG. What are the specifics around that? So talking about suppressant drug effects, increase level of sedation, etc.
Right. So that goes hand in hand with the concept of desynchronization. And to just repeat what you were saying at a basic level, if a drug affects the CNS, we can assume it's going to affect the EEG. There's exceptions to that rule, such as risperidone, which is an antipsychotic drug, which has very little effect on the EEG on an awake patient. But other drugs can have some pretty powerful effects on the EEG, right? Or Keppra another good one. Keppra has very little effect on the EEG, but obviously affects the central nervous system, right? So it's not a rule, but it's a good little rule of thumb to guide you on something. So drugs like benzodiazepines, barbiturates, which are sedative hypnotics, anti-psychotic drugs, for the most part, antidepressant drugs, anti-manic drugs, even stimulants. These oftentimes are going to affect the central nervous system. And again, by going back to the desynchronization concept, they're going to cause desynchrony in one way or another, and that leads to the increase in beta or decrease in the PDR, or at the higher levels start going into unresponsiveness characterized by increase in beta, and then more suppression, and eventually even ECI.
Yeah. Speaking of beta, you've got a really cool alliteration. I know, I've listened to enough lectures to know that you like alliteration.
Yes.
And one of the really cool ones that you say, and I'm going to let you say it. What's the one on beta?
So Benzos, barbs, and booze bring beta. And I love
that. Yeah.
It's got to be the alliteration. It helps you remember it.
Yeah. And you say it with such an enunciation that I just love it. Benzos, barbs, and booze brings beta. I really think that's awesome. So explain to me what that alliteration is actually saying in terms of the EEG.
Yeah. So benzodiazepines, barbiturates, and alcohol, drinking alcohol, booze, all have one thing in common. They're all GABA agonists. So gamma aminobutyric acid, but it's a neurotransmitter. And this neurotransmitter is the primary inhibitory neurotransmitter. So this is going to be the neurotransmitter that's going to stop neurons, brain cells, from doing whatever it is that they're doing. In the case of seizures, these neurons may be firing in a hyperexcited state where they're continuously sending these electric signals, and oftentimes it's likened to a lightning storm in the brain. And so what this drug is going to do is going to bind to these GABA receptors, and it's going to start to inhibit these neurons. So they no longer fire excessively, and the activity is minimalized. So whether it's benzodiazepines, barbiturates, or even alcohol, they all work in a similar fashion to agonize or bind to and work with GABA receptors.
So let's say we're a tech, we get a call to go into the ICU. What patient would you expect that you're going to see an increase of beta if you're looking at their chart, or if you hear their history or something like that? Are there any indicators that you can actually say, hey, you know what? I can guarantee you this patient is absolutely going to have an abundance of beta going on their EEG?
Well, I'm always averse to using guarantee, but
in EEG especially.
Yeah, but I would definitely expect, if I saw things like this patient has a history of insomnia, the patient is a chronic alcoholic, the patient has a history of anxiety. These are often indications for benzodiazepine drugs or barbiturate drugs. Even sometimes patients with eating disorders, they may take a benzodiazepine to help assist with that eating disorder. Patients with epilepsy, I would assume that they're taking a drug that may increase the amount of beta. So
does it matter when or how long it's been since they've taken it? Or, I know that the concentration and the dosage matters, but let's say they take a dosage that brings beta,
right?
And can it, obviously it can wear off, right? Am I assuming correctly?
Correct.
Okay. And then what about, alcohol dependent patients? Are they always going to have beta on their EEG, or is it in a specific time, or does it matter?
Well, I think the key word that you had there was dependent.
Mm-hmm.
So myself, I enjoy bourbon every once in a while.
Yeah.
But
as we did last night.
As we did. But if I had an EEG right now, there'd be no effect from last night's bourbon,
Mm-hmm.
right? If I were someone who took benzodiazepines, like let's just say Ativan or lorazepam, if I was someone who took Ativan every morning to help with my anxiety, then there may be an increase in beta because I'm taking it every day. I have enough of it in my blood to constantly have that therapeutic effect,
Mm-hmm.
right? Over time, your brain is going to get used to drugs. It's going to build a tolerance, especially with benzodiazepines and barbiturates and alcohol. So that effect on the brain may decrease or stabilize over time, but especially right after a dose has been given, or people who are chronic alcoholics
Mm-hmm.
who are going to go home from work and they're going to have a 6-pack, a 12-pack before bed. You know, every day it's more than what a typical person may drink, right? These types of patients, you can still see residual effects on the brain, even if it's been hours and they're no longer drunk or inebriated in any kind of way.
Mm-hmm. That's interesting. And whenever I said dependent and we pointed that out, and you said especially with booze and benzos, is there a common theme that benzos are addictive more than any other, or tend to be more addictive than, a other epileptic drug?
Yeah. So barbiturates, benzos and barbiturates, benzodiazepines and barbiturates are very similar drugs. The barbiturate class is an older class of drugs than the benzodiazepines. And as I was taught, the benzodiazepines were developed as a class to kind of replace barbiturates because they have a lower side effect profile, and most importantly, they have a lower risk of addiction.
Mm-hmm.
And so when it comes to addiction, there's a couple things to really understand to have good context about this. And one of the first is the tolerance. Mm-hmm. With a lot of things, our body is going to build up a tolerance. And tolerance just means that it's going to take more of that thing, drug or food or anything, in order to have the same effect that it used to. So, for example, I am sometimes happily addicted to caffeine.
Yeah.
I love my coffee.
Same here.
And
what's your favorite? Like, are you a latte guy? Are you a straight?
I'm a cold brew black guy.
Yes. Dude.
So,
yeah.
Because that lets me drink it faster because it's cold, and black, I don't need any sweetener or cream.
Yes, absolutely. Absolutely. Okay. Sorry.
So caffeine is a substance that your body can get used to and you can build a tolerance to. Yeah. Sometimes I take little breaks from drinking coffee so that it'll have the same effect on me that I desire.
Yeah.
So with barbiturates and benzodiazepines, the more that you take them, the more of a tolerance you're going to build. It's almost like your neurons are expecting this specific amount of barbiturates, which they just see as GABA. And when it doesn't get that, then they're not happy.
Yeah.
Right. So the tolerance is one aspect of addiction. The other aspect of addiction is going to be your dependency, your psychological or physiological need for it.
Yeah.
And this could manifest physiologically as I have pain when I do not have this drug, or there's something physical that I can see. Maybe I have shakes when I don't have it. Or psychologically, it's this predisposition. I can't stop thinking about it.
Yeah.
I may be anxious or nervous because I'm just thinking about the next time that I'm going to be able to get my fix. And before I continue, I just want to make it really clear. when someone is looking for their drug, this is not a situation where people should be ever looked down upon for it. I hear people all the time saying, they did it to themselves.
Yeah.
And while there may be some truth to that, so did grandfather who had a heart attack because they smoked for 40 years, right? So did someone else who had diabetes because they had a poor diet, type 2 diabetes, because they had a poor diet, or someone who had a stroke because they just couldn't stop eating red meat and ran up their blood pressure.
Yeah.
So self-inflicted diseases are nothing new, and addiction is just as self-inflicted as any other, but also just as serious and worthy of compassion and empathy as any others. So
yeah, and especially when they have to have the medication to get through the day or to treat a specific ailment, and then that dosage can't be sustainable without having some type of dependency, and you're really almost gambling. Is like, hey, I think that's when education comes in. Yeah. Of like, hey, this is obviously an addictive drug, and I choose to believe that caregivers do a good job of doing that. Yeah. Pharmaceutical techs or pharmacists do that, but yeah, that goes back to the education component. And it's unfortunate that that it always starts off with good intentions. But sometimes it goes into dependency, and I think that's well worth calling out. Absolutely.
Yeah, and for me personally, that hits close to home because my mother suffered from chronic pain, fibromyalgia, and injuries that never healed right and stuff. And so before she had passed, she had definitely had some signs of addiction to opioids that she was taking. I remember throughout the years, her doctor would prescribe her a different opioid, or sometimes even increased doses, because she would be saying it doesn't work anymore. It doesn't work. And so he would try a stronger one, or he would switch it up. And it was that tolerance. She was still in pain even after taking the medication. And then other things too. Gabapentin. I'm sorry, not gabapentin, pregabalin, Lyrica. She was taking that, and when she didn't take it, she had very obvious withdrawal symptoms that showed that she had a physical dependency on it. So with drugs like benzodiazepines, barbiturates, alcohol, or any other, where they're building this tolerance, and then we get this physical or psychological dependency, it's addiction, and it really should be something that everyone is aware can happen and should be very careful about. And it's definitely a big side effect of barbiturates more than benzodiazepines by design. Benzodiazepines were less addictive, but definitely a side effect.
And a good reminder to patients or to caregivers is like, if you're taking these medications, to really consult with your physician, and really, if you have any inkling of doubt or misunderstanding, or it's not clear, make sure you consult with your physician when you're taking these medications, because it could lead down a path of dependency that you don't want to go down. And as helpful as these drugs are, there's a dark side to every medication, just like you said, and some are a little bit more than others.
Right.
Well, let's talk about classifications. We kind of teased on that a little bit. So how are drugs classified? And what are the different ways that they can be classified?
So the main ways that I teach about are the therapeutic and pharmacologic classification. And even there's subclassifications, and we can go down a huge, long rabbit hole about this. But I like to just sum it up as either therapeutic or pharmacologic classifications. So either the drug is classified based on what it does, or it's classified by how it does it. So, for example, we can use something like anti-seizure drugs, which is a therapeutic classification. What do these drugs do? They help treat seizures, right? And so we have things like Keppra and Dilantin and lamotrigine and Ativan and all these other drugs, and they belong to many different pharmacologic classes, which is really based on their molecule and their method of action, right? And so I think that may not be the most approachable way to really classify them. You know, to say this is a sodium channel blocker versus this is a GABA agonist. So it's a lot better to just say this is a anti-seizure drug. This is a anti-anxiety, anti-depression drug. Yeah.
And for the students out there who are watching or listening, we're getting into some board questions here. These are the things that you really need to know when you're taking your boards. And one of the questions I have for you is explain broad versus narrow.
So it's
classification, broad versus narrow.
Yeah. So it's kind of like it sounds. A broad spectrum anti-seizure drug is going to be a drug that can be used for many different types of seizures, right? And so you may have something like Ativan, which can stop many different types of seizures, or Keppra, which can work for many types of seizures, versus a narrow spectrum, which is really just meant for that one seizure type or maybe one epilepsy. So good examples of that would be something like ethosuximide, which is really just used for absence seizures, or something like Epidiolex, cannabidiol, which has just been approved for Lennox-Gastaut, Dravet, and I want to say Deuce. There's some others, but originally just for Lennox-Gastaut and Dravet syndrome. So those are definitely narrow spectrum anti-seizure drugs rather than something broad.
Yeah. And now, whenever we say narrow, does that mean that they are the only drug that'll work, or are they combined with other things? And even with the broad spectrum AEDs or ASDs, how does one go about, how would a pharmacist or a neurologist go about trying to really dial in the medications that these patients need?
Let me first start by just tackling whether or not it'll work for that one seizure and only that one seizure. And the answer to that is no, but maybe sometimes. Depends on the patient. Really depends on the patient. And that's where we have to remember the variety of patients in the same way we remember the variety of humans. You know, I might really like bologna on my sandwiches. Someone else, my daughter, hates bologna. Can't stand it. I love it. But everybody's a little bit different. And when it comes to anti-seizure drugs, even if we're talking about narrow or even broad spectrum, no single drug is going to work for the same seizure for every different person. You can have two different people with the same seizure type, and one drug might not work for them. It might work better for person A, but not person B. Or, I mean, you might get lucky and it works great for both. So there's a lot of interperson variability when it comes to deciding what drug is going to work for each. And so some of the factors that may go into that might be tolerance with the adverse effects. Like I said earlier, Keppra is known to cause some irritability. It's also known not to create a lot of the really serious adverse effects. It's not causing gingival hyperplasia or Stevens-Johnson syndrome or anything like that. But just because it doesn't create a really obvious adverse effect doesn't mean that patient A and patient B will tolerate it. Patient A may not be able to tolerate what it's doing. They may not like how they feel on it. Or their parents may not like how they are on it, or caregivers or whoever's around them. Whereas patient B on the same drug might actually have some adverse effects that make it difficult for them to be able to take the drug, like nausea and vomiting. And some adverse effects may be a little easier to tolerate as their body gets used to it. The adverse effects may fall off a little bit. So that's another thing to consider. Is this patient having these adverse effects, and will they get better for that patient? or will they not get better? And so we got to deal with the efficacy of the drug. Is it going to create the treatment, the prophylactic that we want? And is it going to have a tolerable side effect profile? And is it something that the patient's insurance will cover?
Yeah. Yeah. That's also something you have to consider. Is there a first line, a general first line for, like, let's say general tonic-clonic GTC coming in that is typically used for, a specific, for example, the GTCs, they come in that we're going to hit them up with this specific therapy to try to stop it. And then you go from there? Or is it something you look at the history, okay, that probably won't work, let's try this other medication? Or is it just hit and miss?
I don't believe that there's any one algorithm to be used in choosing the medication. For example, if a patient comes in and all they had is a generalized tonic-clonic seizure, first, we need to know, are they going to have another generalized tonic-clonic seizure? Is it something that is going to repeat? If this is their first onset seizure, is this new onset epilepsy, or was there a trigger, right? So let's assume that it's epilepsy, and we know that this patient is going to have more seizures, and so the goal is prevent as many seizures as we can. We also need to kind of work out what kind of epilepsy there is, and this is where EEG tech's coming up with very, very good, clean, optimal recordings play a huge role in this, because the better our recording, the better the neurologist is going to be able to diagnose this patient. So we have to look at the type of epilepsy. So are they having a generalized tonic-clonic seizure because they have primary generalized epilepsy? Are they having a generalized tonic-clonic seizure because it's Lennox-Gastaut? Is it juvenile myoclonic epilepsy? So many different epilepsies, and many epilepsies have more than one seizure type, right? So, and then there's different presentations of these epilepsies for each patient. So really the best regimens are going to be tailored to that individual patient, while there may be some that are a go-to for that patient to start. Yeah. Right. We may say, or a physician may say, I'm going to go ahead and use valproic acid because this person appears to have juvenile myoclonic epilepsy. Maybe they're just having their seizures during breakfast every day, or, something that really says that's what's going on. Then they may try that first. And that's because it's one of the most effective drugs for it. But it may not end up being the prophylactic that the patient needs. So they may still be having seizures, or it might help with one seizure type, but not their other seizure types. So then they'll go on to another drug that may work better, and then try different options.
Yeah.